One toxicity that is quite common with T-DXd is the risk of nausea and vomiting. We know that T-DXd is classified as an agent that is considered to be highly emetogenic, and that means that it is really critical to use prophylactic antiemetic therapy when treating patients with T-DXd. Antibody drug conjugates have really become a mainstay in the treatment of patients who have metastatic HER2 positive breast cancer, with availability of two different antibody drug conjugates. One is trastuzumab deruxtecan, also known as T-DXd, and another is trastuzumab emtansine, also known as TDM1. T-DXd is really a second-line standard of care based on data from DESTINY-Breast03, where we had seen an unprecedented 29-month progression-free survival with T-DXd in this setting, with superiority compared to TDM1. So when we're using these antibody drug conjugates, it's obviously very critical to think about how we can optimally manage toxicities from therapy. And one toxicity that is quite common with T-DXd is the risk of nausea and vomiting. We know that T-DXd is classified as an agent that is considered to be highly emetogenic, and that means that it is really critical to use prophylactic antiemetic therapy when treating patients with T-DXd. And so one of the first things that I think we do is we make sure that patients are very well informed about the potential risk of nausea and what the timing of nausea is, because with T-DXd, there can be two different timings, I think, of with nausea. One can be the acute impact of the drug. So if you're getting treated, usually within those first 3 to 5 days, there is risk of nausea. But there's also delayed nausea that can occur. So usually during weeks 2 and 3, there are some patients who can get this delayed nausea. And so it's important to make sure patients are aware of this and that they're also informed how we are going to work to prevent and treat that nausea. So again, a discussion up front, I think, is quite critical. I do think about using a 3-drug prophylactic regimen because, again, this is a highly emetogenic agent. And so that means that I'm usually utilizing dexamethasone with a 5-HT3 and an NK1 antagonist up front, really to prevent nausea. So that means that they're getting those 3 drugs prior to their T-DXd infusion. And then when they go home, I make sure that they're informed that they should be taking that dexamethasone for the next 3 days to help prevent nausea. I also make sure that they know that if, despite getting the 3 drugs on day 1 and then the dexamethasones day 2, 3, 4, that they have medication at home that they could use in case they get nausea despite having gotten all of those agents. One drug that can work well if someone has breakthrough nausea during that first 5-day period is olanzapine. This medication is something that I tell patients to use usually in the evening because it can make them drowsy. And I do tell them to use a small dose at 2.5 milligrams in the evening. If, however, someone got all that stuff and still developed significant nausea from the get-go, then I do adjust their regimen the next cycle. I'll also give them olanzapine on day 1 to help try to prevent that nausea from emerging over the next few days. Obviously, we still need to be keeping in close contact with patients, monitoring them for nausea, and make sure they know to call us if they're having trouble. But I do make sure that they are informed that if they get delayed nausea during, for example, week 2 or 3, that they know how to use either olanzapine for that breakthrough nausea or to use ondansetron. Either of these agents I find works very well, particularly for that delayed nausea over that, week 2, week 3 timeframe. And so, using 8 milligrams of ondansetron as needed up to 3 times a day, every 8 hours, I find works. Do warn people so that it can make you constipated or cause some headaches. And with olanzapine, again, I use that small dose, 2.5 milligrams at bedtime, which again, people find does work quite well. So it's important to make sure you prescribe these drugs to patients up front so they have them at home to use in the event that they do have breakthrough events. So outside of nausea and vomiting, there are other potential toxicities that we should be aware of with T-DXd, one of them being fatigue. I find that educating patients about trying things like exercise on a routine basis can be quite helpful with fatigue. But I think if they've made adjustments and they're not helping with the fatigue, one of the things I do consider is dose modification. The other thing to be aware of is that about 10 to 15% of patients receiving T-DXd may develop interstitial lung disease, so inflammation in the lungs. Most of this tends to be low-grade toxicity, but there are rare occasions where this can be serious. So please make sure your patients are aware of this potential risk. They're reporting it to you and you're monitoring for it as a potential toxicity. So overall, I will say that we have seen quite a revolution in outcomes for patients who have metastatic HER2 positive breast cancer, really due to the introduction of antibody drug conjugates, where we are seeing patients live longer because of these drugs. And so it is very critical to be able to have these as options for patients, but also equally critical to be able to monitor for side effects so that we can make sure that patients are living well with therapy. And so do be cognizant of some potential toxicities. Make sure you are prophylaxing, in particular for nausea, with the use of T-DXd, and monitoring for potential risk of ILD. For additional details and downloadable adverse events management protocols, please refer to the slide deck. Thank you so much.